J'avais une question sur les comorbidités. C'est une situation à laquelle j'ai été confrontée récemment. Plusieurs patients qui ont des diagnostics justement de troubles bipolaires et de troubles de personnalité borderline et qui ont peur d'être moins bien soignés s'ils n'ont qu'un diagnostic bipolaire, borderline, pardon, et qui du coup sont dans cette ambivalence-là sur le diagnostic et comment est-ce qu'on peut les aider à mieux accepter le diagnostic borderline.
Really common problem in the US. There's even a number of celebrities that say that they had DBT, but they also say they have bipolar disorder. And it really just goes to show that in society at large, people think bipolar disorder is more legitimate somehow. And it is a serious disorder, but you also see that it commits people to a lot of medication management that they may or may not respond to. And so, you know, even the case of Selena Gomez, she's talked openly about how she has received DBT, but she also claims to have bipolar disorder, and she's been in the press a lot because she's gained a lot of weight from the medications, and she also has lupus. So it's I don't claim to know her medical situation, but there are pros and cons to the different outcomes. Brad Reish, who's in our lab, he wrote one of the original studies on lamotrigine that showed that it was effective for BPD because it was a very short time course. He's actually now doing a longitudinal study to differentiate bipolar 2 from borderline. And we can tell people that there's a lot of confusion because phenotypically it looks the same features, but we actually know the underlying mechanisms are different. So it can be confusing, but you can say, well, if we find the right mechanism and treat that, you're going to have a better outcome. So let's keep an open mind, and you will be my partner in experimenting with what works and what doesn't work. So if you're on medication for bipolar disorder and you're still having a lot of crises that aren't necessarily classic bipolar episodes, maybe we should help you with some skills. And we know that DBT, even for people with bipolar disorder, it improves outcomes. There's no bad side effects for the BPD treatments, so people who have bipolar disorder, if they get DBT, they have better functioning inter-episode, they're more adherent to treatment, and less likely to have another mood episode. So, you know, we kind of say in GPM, just do what works.
Merci beaucoup. En fait, j'ai une petite question parce que ce matin, vous avez dit dans l'une des interventions qu'il n'y avait pas forcément de contexte de maltraitance en fait pour développer après le trouble de la personnalité borderline. Mais en fait, en clinique, ce qu'on observe en réalité, c'est même si ce n'est pas de la maltraitance au sens strict, il y a quand même toujours un contexte maltraitant, dans le sens où on retrouve systématiquement, enfin, de mon expérience clinique, au moins chez un des deux parents de l'adolescent, ou une personnalité ultra pathologique, ou au moins un trouble psy, c'est-à-dire au minima un syndrome dépressif ou des épisodes dépressifs récurrents, voire une schizophrénie ou un alcoolisme, etc. Et en fait, je n'ai jamais vu de trouble de la personnalité borderline, enfin qui consulte en tout cas en dispensaire, etc. public, sans qu'il y ait ce contexte familial, pathologique au sens large. Voilà, c'est ma première remarque. Et voilà, après j'en ai une deuxième, mais je ne sais pas si vous voulez répondre.
Yeah. That's also something that was obvious in early family studies. And so the last big research study that John Gunderson had funded was a family study because we were really interested in the question of whether or not impulsivity, emotional or affective instability, and interpersonal problems ran in families separately. Some people have behavioral problems like substance use, some people have mood disorders, or if they run together. And actually the statistical model favored that there's some sort of latent factor that causes the phenotypes of mood, substance, and other problems to be more visible in families of people who have BPD. So we don't really understand what that latent factor is, but some scientific studies point to stress sensitivity. So you know the serotonin transporter kind of haplotypes, the finding that there are the short and longer alleles, and they differentiate people who are more prone to have some psychiatric outcomes like depression or anxiety in the face of stress. We think that that is just a kind of common risk factor that converges with other risk factors. So for some relatives, they may deal with some problems, and it may be most obvious as a substance use disorder. But I would imagine there's some interpersonal process in there, but the dominating kind of descriptive or behavioral phenomenon is the substance use disorder, and that's what needs the most treatment. But the cumulative risk for the person who expresses BPD is just like a kind of multiple hit outcome for having the same vulnerabilities, but maybe more adversity and stress, so they have more broad dysfunction. Does that make sense? But the true answer is we don't know enough about it yet, but it is true that people with BPD tend to have families that have more psychiatric diagnoses than people who don't have BPD, but it's not necessarily as obvious as one generation having BPD and then the next generation having BPD.
Oui, merci. Et du coup, j'avais une autre question, parce qu'on voit souvent dans les diapos et même dans les interventions différentes sur le sujet de la personnalité borderline, on voit la notion de sentiment de vide. Enfin, souvent, les collègues emploient, il y a un sentiment de vide, etc. Ça fait partie des critères, voilà. Mais c'est vrai qu'en clinique, encore une fois, je trouve que, en fait, personne n'est vide en réalité. Donc, je ne vois pas très bien, moi, personnellement, dans ma pratique, à quoi ça correspond, ce terme, parce que je le vois dans tous les livres. Mais le vide, alors, moi, j'ai ma propre petite conception, mais je ne sais pas si vous la partagez ou pas. Mais pour moi, le côté vide, c'est un mélange de colère, de culpabilité et de protection d'un certain système environnemental ou souvent parental. Et c'est ça qu'on appelle vide parce que l'adolescent ne dit rien, on n'a pas accès. Alors est-ce que c'est ça le vide ou est-ce que c'est autre chose et que je ne vois pas à quoi ça correspond du coup, je veux bien qu'on me l'explique.
I think that it's a complicated question, right? And I think that the most interesting thing that I've experienced in my life work is that people with BPD and their families describe it in different ways, but it seems to kind of overlap in some ways. So these problems of heightened aggression, that's the TFP theory, or failed mentalization and attachment insecurity, that's MBT, or emotion dysregulation and lack of skills, or interpersonal hypersensitivity, all the patients they relate to all of these models in different times and places. So I don't think there's any one answer to that, but if you ask a person about their life story, the problem with a person who has BPD is that they have a lot of identity diffusion and uncertainty about themselves. So at first, they may not know, but as they become more cognitively clear, they will become a little bit more aware of what factors led to BPD for them, and no two people are alike. So for example, because I've worked with a lot of families, I've learned a lot that the family configuration is very specific to each child. A lot of families where there's someone who has BPD, they have another child who doesn't have BPD, or they have other children who don't have other problems. And it can have to do with where the parents were at that time of life. So maybe the parents have their own family crisis, like someone in their extended family is having trouble, so they're different parents with a sensitive child, and it's a combination of inborn problems with the environment that they're born into. So another example is that there was a patient who was very difficult to treat. She came from a family, very nice parents, but she was born with a high degree of aggressiveness. She was like punching people in the sandbox when she was 5. And her parents just didn't relate to her because they were very well educated. They had 2 other daughters who were perfectly friendly and not aggressive. And so she just ended up feeling like she was a bad person, and the problem never got resolved. So, you know, different people will have different problems, and it's both the hand you're dealt biologically and then the kind of situation that you're placed in that then determines your risk for BPD. So I wish there was a good answer, but. Oh, emptiness. Okay, emptiness. The emptiness is also a very interesting thing, because when you ask a person who doesn't have BPD what this kind of characteristic of emptiness is, people don't know what that means. But when you ask someone who has BPD, they're like, oh, yes, I have emptiness. And there's actually a video I did on Borderliner Notes talking to a person with lived experience who said they never had it, but there's a huge chat about what emptiness is. Some people call it the dead zone. You know, it's just a feeling of deadness inside. Some people feel like there's nothing inside that's knowable or stable. So some families have said it's like you're trying to fill up a colander, but the water keeps leaking out because their sense of self doesn't contain them. Some people say it's a physical sensation in their belly, that there's just like something inside that they don't know how to describe. So people will describe it in very different ways, but when patients endorse emptiness, that's actually a very specific feature that not a lot of other patients with other disorders will describe. But people with BPD, they'll often say, oh, emptiness, definitely, I have that. And they'll describe it to you. So you can ask them, you know, what is it that you relate to when I say this kind of feeling of emptiness? And they'll typically tell you, but not all people will meet that criteria. And it depends on the patient.
And what are the relationship between emptiness and dissociation?
Okay, emptiness and dissociation. So emptiness, I think they're both poorly defined terms, but nobody really is that focused on emptiness. Dissociation and detachment and avoidance, those are oftentimes confused. So dissociation is a kind of coping strategy to separate yourself from your own experience when your stress level is too high. And that happens, it's most typically kind of related to traumatic reactions. So we all dissociate a little bit, like when I don't like roller coasters, when I'm riding a roller coaster, I intentionally dissociate. That kind of thing is a psychological adaptation to cope with something that you want to block out. Numbness and emptiness is a little bit different. It's that if you don't have an independent experience of yourself, you're always contingent with your context or how people are reacting to you, and then you're alone. There's something that's vacated in you. Your sense of vitality and aliveness is so contextual that that feeling of aliveness can come and go with your life situation. That's less purposeful than dissociation. I think emptiness has to do with the identity problem. Dissociation is a cognitive management of stress. So that's how I tend to differentiate them.